So now, without waiting, we will begin. I would just like to invite Dr. Mihir Jani, who is first year resident at SSG Medical Baroda, to introduce our esteemed speaker, Dr. PSVN Sharma, sir. Dr. Mihir.
Thank you, sir. Good evening, everyone. Good evening, everyone. I am Dr. Mihir Jani, first year resident student at Medical College Baroda, Gujarat. A very warm welcome to all of you, and thank you all for joining of today's webinar, which is about how to pass the final postgraduate examination. That we are the person who has years of experience in teaching and training of undergraduate and postgraduate students, and I feel privileged and honored that I got the opportunity to introduce a person of such high caliber, Dr. PSVN Sharma sir. Dr. PSVN Sharma sir is a professor of psychiatry at KMC Manipal. He has done his MBBS from Maulana Azad Medical College, New Delhi, completed his diploma in psychological medicine from NIMHANS, Bengaluru, and pursued his MD from PGI Chandigarh. He has served at various institutes such as NIMHANS, CIP Ranchi, and rendering his services at Kasturba Medical College, Manipal since 1988, where he heads the Department of Psychiatry. His areas of interest are PG, it means postgraduate training, psychiatric rehabilitation, and descriptive psychopathology. Like all of you, I am also very excited to hear him so. Let us not waste time, and with all my due respect, I would like to call Dr. PSVN Sharma sir for his wise words. Over to you, sir.
Thank you. Let me just share the screen before I start. Okay, good evening. Is the screen visible?
Yes, sir, it is visible.
Yes, sir.
Okay. Firstly, I would like to give my profound gratitude to the Indian Psychiatric Society and the coordinators of this program for giving me an opportunity to be with all of you, senior people, my colleagues as well, especially, and also the future psychiatrists of this country. In the next 45-50 minutes, what I would like to tell you is about how to prepare over the 36 months that you'll be doing your MD, and then how to end up with the examinations themselves, and a few things that I've learned over the years as being a student, a teacher, and then subsequently also as an examiner that I will share with you. So how to clear the final postgraduate examination? Is there some way that I can move? Because it's obstructing my slides. Okay, anyways. Yeah. So the theory and clinical program, what is the expected trajectory of learning during your course of MD over 36 months? So the first 6 months is going to be tough for the new people who are going to come in, because psychiatry unfortunately still does not receive the sort of attention that it should at undergraduate level. But in the first 6 months, you will need to start learning about psychopathology, and you need to learn about whatever classificatory systems that you're going to use, whether it is ICD, DSM, whatever. You need to learn about an overview of disorders, not in depth, but overview. And then you will also have an introduction to basic sciences, which is neuroanatomy, neurophysiology, neurochemistry, genetics, and social sciences like psychology, clinical psychology, psychiatric social work, and so on. And you will receive basic training in interviewing and allied clinical skills that go with it. And unfortunately, now you also have to submit a dissertation plan. So that's quite an ask at the first 6 months of your PG career for somebody who's had very little exposure to psychiatry, but that's the way things are. So you may rely on Fish and Sims, which is commonly used, or any other equivalent book for psychopathology. I put a question mark in front of Jaspers, not because I question Jaspers, but because I think that at that stage, Jaspers will be a little difficult to follow. A German text which has been translated into English. It's a wonderful text of descriptive psychopathology that all of you must read at some point in your postgraduate days. And then you can choose any basic textbook of psychiatry, something which is simple, to get an overview of common psychiatric disorders that you will be dealing with in the OPD and in your wards. And then, of course, you need to know the current ICD and the current DSM classifications. That's at 6 months. You need to learn from live patient interviews. Your faculty will be interviewing patients. Your seniors will be interviewing patients. That's the time when you need to look at them and look at how the interviewing is going on. Don't look at your cell phones at that time, but be learners, even if you're not directly interviewing the patient. If you have access to videos of interviews in the languages that you use, please go ahead and do it. And then there are, of course, plenty of case vignettes around which you should read and then try to understand the type of psychopathology that is being described in those case vignettes. There are accompanying books for the DSM. There are various books which give case vignettes. Now, I want to here make a very significant distinction between what is a clinical presentation and a clinical guideline. You must understand that most of the textbooks that are currently available to us will give you clinical guidelines, some sort of descriptors of what sort of symptomatology, a few symptoms that the patient may come with. Whereas a clinical prescription, a presentation is a much richer description. Usually clinical presentations are what have been written in earlier days in single author textbooks of psychiatry, where personal observation, the psychiatrists have looked at each patient from all angles and then distilled out what they have observed. Now, that is what actually you will see when you start seeing patients. So while you should know clinical guidelines, I think you should read clinical presentations. And for that, you probably have to go back to books which are slightly older in terms of textbooks of the date of publication, but which are replete with great descriptions. Like, for example, you could go back to Mayer Gross. You can go back to Noyce and Cole. There are many such books. There are more current books also by youngsters which talk about clinical presentation. So I want you all to try to access clinical presentations also, in addition to just clinical guidelines for making diagnosis. By 12 months, you should be knowing details of disorders. You should be knowing something about the type of treatments. Your basic sciences gets into the picture, social sciences. By then, you're also learning research methods. You need to be learning about the theory and planning and executing of research because you're into your dissertation. There are therapeutic management planning that you have to learn, and also the implementation of that plan. You need to get into therapeutic skills, diagnostic skills. You need to become aware of psychological tests and testing, casework, psychosocial aspects, and psychotherapies of different forms. So this again widens the scope of your learning from the 6 month to the 12-month period. Now, at the same time, learn to do a thorough physical examination, including a neurological and lobe functions. Now, it's going to be your bread and butter to do neurological examination and lobe functions. Believe me, even now, at this age, I get surprised when I miss certain signs and I'm not able to distinguish an organic etiology of any type in our patients. What happens sometimes over time is that we sort of start looking only for psychiatric diagnosis, and we stop keeping our minds open to other coexisting or causal medical diagnosis. Okay, we still belong to the medical specialty, so we still need to have those medical skills. So this is extremely important to learn how to do a detailed physical and neurological examination and lobe functions. Again, observe and learn, interviewing, therapeutic, and presentation skills. By now, you will be seeing your seniors present in seminars and case conferences, etc. You'll be seeing your teachers present in conferences and so on. So start learning those skills also by this time. And I would suggest do as many detailed evaluations of patients as possible, psychiatric evaluations, as many as possible. Discuss these with your seniors, make management plans, then take up therapies and learn procedures. Procedures include things like ECT, LP, TDCS, whatever are the procedures that are practiced in your teaching department. But grab this opportunity. Of course, today being a COVID time, I know that all of you and all of us are disadvantaged in many ways. We don't have access to patients because the patients are not able to come to us. But I'm sure that there will be a brighter tomorrow, probably 2 months, 3 months, whatever. So this applies to that time. But grab your opportunities to do evaluations, as many evaluations as possible of your patients. Coming to 18 to 24 months, you should start focusing on specialties. Okay, neurology is one of them, recent advances is another. And then, of course, fine tune your clinical and therapeutic skills. This is the time that you start reading advanced single subject textbooks also and review articles. There are many single subject textbooks. What comes to my mind is ATPD by Sasser and Wonderling, okay, or Jameson's about bipolar disorder. There are many like that. Your teachers will tell you. So start reading these specialty books. And this is also usually time for peripheral postings and your thesis data collection completion. At 30 months, you've done your thesis or dissertation submission. You're doing your writing up of papers. You're completing your therapy hours, depending upon your university guidelines, how many supervised therapy hours you should have done. And you should also be collecting material to study for your final examination. Now, this is important. You should plan and make a viable reading and revision timetable for the next 6 months, because this is your workup to your examination. So see what your strengths are and what your not so strong areas are in terms of theory and practice, and then make a plan for yourself. Also decide how many times you have to reread in order to be well prepared for your examination in the next 6 months' time. This is the time to make that plan. At 30 to 36 months, this is your final preparation. I would suggest you should plan for at least 3 complete readings of every topic. I remember that when you're reading from your books, or even if you're using technology and tablet or whatever, make margin notes. They are very important in 2 ways. As you're reading, you grasp something. As you scribble on the margin, you're again reinforcing that learning. So it's extremely important that you should make some margin notes. It's a shorthand that only you will understand. That doesn't matter, because at the last revision, these margin notes will help you a lot. Enlist, this is another thing which we used to do as students when I was in NIMHANS, when I was in PGI. Enlist your juniors to read up topics and teach you. Okay, give your juniors a particular topic, let them read it up, let them read up the references, let them come in the evening and teach you whatever it is that they want to teach you. That will be an excellent help for you. Give them a treat, give them a dinner if they need it, but use their help also. Okay. Then next is time yourself by writing sample short and long questions. Okay, your different universities have different patterns. Some have long plus short, some have all short, some have brief notes. So it's difficult to give you any specific guideline, but practice the timing of the average paper, how much time you will require to address each question. Okay, so that's important because you shouldn't run out of time at the end. Okay, I also practice how to make a case summary, a case formulation, and a management plan. I'm sure you will know, or you will be told, what is the difference between a case summary and a case formulation. A case summary is easy. It's like a précis of the whole history, etc. A case formulation is how you handle the data that you have obtained from the patient and how you interpret it to reach a particular conclusion and management plan. So there is a very distinct difference between the two. So you should know how to practice making case summaries, case formulations, and how to make up a management plan and how to check whether your management plan is working or not. These are all the things that you try to sort of streamline in the 30 to 36 month period. Again, practice, although you have already gone to your neurology posting, now is the time to revise your EEG, imaging, psychological test materials. If your university asks for specimens, etc., cut specimens of the brain, that also practice all these at this time because they'll all come up in the examination. Important at this time, don't try not to psych yourself, try not to get too anxious about it. At the same time, don't psych others by saying, oh, I don't know, please help me, I don't know. All of you are in the same boat. All of us have been in the same boat in the past. You will do fine. Just try to focus and divide work and play in the way it should be done. I have a few reading suggestions, not for psychiatry, because there's plenty of options and plenty of things that people will tell you. But the things which are neglected, for example, general psychology. You could look at Barron's, the 5th edition, developmental psychology, Sandrock, abnormal psychology, Saracen, or social psychology. Kuppuswamy is a little dry, but Barron and Byron are fine. Psychotherapy, any book by Sidney Block is very good. Neuroanatomy, you can look at different books that you need, and similarly neurophysiology. Neurology, I think the neurology section of Harrison should suffice. Of course, for clinical method, you should at least use Bickerstaff. You must have a look at Leishman or Cummings, and then Levinson for psychosomatic medicine. So these are the books that definitely you must have a look at during the course of your reading. And then genetics, Schultz and McMahon is what I think is pretty decent. You can go for something higher also, that's not a problem. Then treatment guidelines, you should know a few treatment guidelines. You know, IPS guidelines you must know because they are your own guidelines. And then there's a Maudsley, there's APA, there is NICE guidelines, there are many other guidelines. Depending upon the emphasis placed in your department on the teaching, you can choose any of those. We have no problem with that. All of them are more or less evidence-based, so it's fine, but you should know treatment guidelines so that later when you practice according to treatment guidelines. Now, suggestions for your preparation: overread. Don't read once and then leave it like that. Read it again and again and again. If you're reading about the description of schizophrenia or the genetics of schizophrenia, you have read it in first year, don't think that it's enough. Go on reading in second year and in third year because it takes time for these memories to sort of get encoded and sort of stay in your mind. Okay. So don't leave things for one read. That's not of any use, especially when you're reading a lot of things. Second thing, read from multiple sources. You know, at postgraduate training, especially in psychiatry, there's no point sticking to one textbook. That's not enough, nowhere near enough, because each textbook and each author gives his or her perspective. But there's a vast ocean of other differences. And not only are you becoming an MD psychiatrist, but you're also going to be eligible to become a teacher. So that's a bigger responsibility. So the scope of your reading should also be reflected in that. So read the same thing from multiple sources, you will get different perspectives. And then you build up a structure in your head of that particular thing, which is very conceptual and very, very, which will accommodate new facts very well. Whereas if you read only one source, then it will be difficult for you later on to accommodate new facts. Grasp always the historical evolution of constructs. Okay, psychiatry, most of the disorders that you're reading about now have had a very complex course in time of how people have defined these disorders and how they have understood these disorders and so on. So look at the historical concept. Don't just leave that alone and read only the treatment guidelines. Okay, that historical construct is important. When you read a topic, read it as an evolving concept. You're on a point. You're on a point in the evolution of a concept. It's not a given. When you're reading psychiatry today, it's not a given. It's an evolving piece of work in progress. Tomorrow there'll be new things to add on to this concept. So look at it from that perspective, like building blocks. Okay, so don't say, okay, this is it and it's over. No, keep your minds open. It's extremely important to write notes. That is still useful even in the days of technology and devices and so on. Whatever way you do it, as I mentioned earlier on, please write notes and refer back to them. It's very, very important. In your mind, cross-reference what you read. You read about schizophrenia description one day, you read about medicines the other day, you read about response to drugs the other day, you read another thing about resistant schizophrenia the other day. Keep cross-referencing them. Oh, I read this yesterday. Oh, I read this day before. Put them all together to build up your own mental representations. And that helps you in future also. Now, for the other things, the reading in social and behavioral sciences, all of you know that there is very rudimentary exposure in MBBS time. The maximum you get is a few chapters which are related in community medicine. Very often there is a stepmotherly attitude towards these, which is unfortunate, but which is a reality. And it's often neglected in training also. Remember one thing, this is actually your clinical science of psychiatry is rooted in social and behavioral sciences. When you're talking about abnormality, you are talking that in comparison with normal. And unless you know what that normal is, it becomes very difficult for you to define what is abnormal. It is very difficult for you to understand why a child has ADHD or why it is diagnosed as having ADHD unless you know developmental psychology. Okay, so it's extremely important for you to read about social and behavioral sciences. Similarly, it is important to know the social context of our lives and the sociology of our lives to understand what the person is feeling and suffering from. Regarding basic sciences, again, the exposure in MBBS is very, very rudimentary. There is no exposure whatsoever to functional and behavioral aspects beyond saying there's something called the limbic system. You're not taught anything else, and which is next to nothing. So remember, however, that if you call yourself a biological psychiatrist and you read Stephen Stahl, then you must remember that the very edifice of biological psychiatry is based on anatomy, physiology, and things like that. In the examination, an examiner will ask you, point out to me in this brain specimen, which is the ventral striatum, which is the nucleus accumbens. Now, unless you know the place where it is and its connections, simply talking about nucleus accumbens and the reward system or ventral striatum and its role in obsessive compulsive disorder doesn't make sense. They're just disparate facts which you will soon forget. So you have to base them in the basic sciences. You have to read. If you have access to anatomy museum, you should go back to that. So read these subjects with gross specimens, slides, and other aids also. Now, regarding psychiatry, there is always this tussle, should I read a textbook? Should I read a comprehensive textbook? Should I read a handbook? In the beginning, in your first year, read a handbook. When you move to second year, you need to read a mixture of a comprehensive textbook and a textbook. The difference is this: a textbook is often written by a single author. So the style in it remains the same. The readability remains the same. Okay, you can read it like a storybook. Whereas a comprehensive textbook usually is multi-author. And you see those breaks from chapter to chapter, chapter to chapter. However good the editors may be, you see that there are differences in styles, differences in emphasis, and so on. So you need to ask your seniors and your faculty which chapter is good in a comprehensive book, which chapter is good in a textbook. Should I read this chapter from Tasman, this from postgraduate psychiatry, this from 3TP? Ask your teachers and they will tell you, but make it a mix of both. Don't stick to only comprehensive textbook or only a textbook alone. Single author, I told you, there is an advantage. Multi-author also had advantage because multi-author has more in-depth, more detailed, more up-to-date information about a narrow area. A single author book has a very vast canvas. It's important to have a compilation of scholarly articles that you must read. You know, articles which are very important, which have been path-breaking in nature. And you should look at important reviews, other journal articles, as treatment guidelines and systematic reviews you talked about. Now, this is very important. Historically significant, or what we call as seminal articles in the original form. Okay. Slater's Hysteria is a seminal article. You need to read it in the original form. Okay. Expressed Emotion is a seminal article in the BJP. You need to read it in the original form to get a flavor of what it is, because what you're seeing now 20, 30 years later, you need to link up with how it all started then. Okay, to give you a well-rounded knowledge. So pay attention to these. There might be about 15, 20 suggestions that your faculty will give you as seminal articles. That's enough. That's fine. But it helps you create a strong bedrock of knowledge in your mind. Coming to neurology, a standard textbook is fine. I suggest reading the neurology aspects of Harrison. That should be fine. What are the neglected areas? The problem is that we have a preoccupation with F10 to F39 in our day-to-day work. So this leads neglect to other areas in the classification, especially ICD. So these are the huge things that we neglect: forensic, geriatric, gender-related, deprived and disadvantaged sections, genetics, advances in biological psychiatry, psychology, sociology, therapeutics, research methods. Look at the list. All of them are very important for us. So we need to make up, if we don't discuss it clinically in the day-to-day basis, we need to read about it at least and discuss about it. Some of this will be done in your seminars, in your department. Some of this will be done by guest lectures, etc. But you need to put in your effort also. Yeah. So what is it that you should have achieved by this point in time? Okay. You should have achieved clinical interviewing skills and interpersonal sensitivity. You should be able to formulate a clinical problem and evolve a management plan. You should be able to carry out that management plan and self-audit as to how it is working or not working. You should be able to understand psychosocial interventions and their relevance in psychiatry. Psychotherapeutic skills are important, and a minimum number of supervised therapy sessions you should have under your belt. Important, empathic, non-judgmental worldview, extremely important for us, and an interest also in areas which are laterally related to psychiatry and research methods is very good, because we are sort of on the fringe of sociology, we are in the fringe of psychology, we are on the fringe of philosophy, on the fringe of politics, we are on the fringe everywhere. So having some basic interest and understanding of these areas enrich your life. Now, what helps to deal with these targets? Apart from regular reading, case taking, and managing patients and attending academics, it is to your advantage to have a 6-monthly written test in relevant areas of the syllabus and get feedback from your staff. It's also important to have periodical clinical examination, long case, short case, viva with your faculty to prep you and get their feedback again. Don't be afraid of these assessments. Don't bunk them. Don't be scared that, oh, I will fail, etc. Just go, face it. And then you will realize that you can learn a lot from that experience. And they will definitely help you in the long run. Coming to the theory paper. Format of questions, you can have long answer, you can have short answer, and you can have a combination. Sometimes MCQs. There was a move earlier on in MCI that the 4th paper in your MD paper, 4th section should be all MCQs. It didn't work out then, but I see that over a period of time, a part at least will become MCQs. So the formats may differ. What happens on the day prior to the examination? What do? Do you sit and cram? You stay awake till 4 in the morning? And you get anxious and walk in the corridors of your hostel? Do you complain to your neighbor that I have not learned anything, I don't know anything, I've forgotten anything, please help me? So try not to be anxious, try to realize how much you have read, and yes, that is all I can read. Let me get a good night's sleep. My strong advice for you is sleep well on the night prior to your examination. Get at least 6 hours. It will help you. You know sleep physiology. You know what it does to improve your functioning the next day. So practice it. So on D-Day, what happens? Read your paper carefully. Okay. Don't hurry to write. First, read all the questions. Understand what they are asking. And then spend some time, especially to understand conceptual questions, long questions, questions where you have to pull things together from different sources to make your answer. Okay. And then make a skeleton answer. Especially if it's a conceptual question, try to make one skeletal answer and see how, and then flesh it out. For example, if the question is concept of dissociation, its manifestations and nosological status, make a skeleton like, okay, I'll make an introductory comment, then evolution of the concept, important milestones like Greek history, Ayurveda, Janet, Charcot, Freud, other schools, St. Louis, somatization, recent changes in conceptualization, differentiation from malingering. Then I'll write manifestations. Then I will write about the evolution of the nosological schema with research evidence. Make that sort of a skeleton in the back sheet of your paper and then fill it out. Okay. Yeah, okay. So that helps you. The 2-3 minutes that you do in planning your question cool-headedly will help you write a good long answer question. There is an importance of diagrams. Please remember that. But make diagrams only when they will explain what you're trying to say easily and saving time. Okay. But then it need not be nice sketches from Gray's Anatomy. It can be just boxes and line diagrams. That is fine. There's absolutely no problem with that. You can write textual answers, but remember that you're not getting any marks for prose. Okay, however good your prose may be. So since you will be hard pressed for time, you can easily write point-wise answers. It's just 1, 2, 3, 4. That's all, and save time. So there's perfectly no reason why you should write textual answers. Now there is underlining is important, but then sometimes we may go overboard with underlining, and then it becomes ridiculous. Take this example. The question is, what are the features of mania? So this person writes, important feature of mania is elation, underlined. It is important, underlined, to elicit irrationality, underlined, intrusiveness, underlined, indecisiveness, and it goes on. And then they use multiple colors and make a painting out of the answer book. That is distracting in nature. That doesn't help. Okay, you just underline what is extremely important, because when you underline, you're drawing the attention of the examiner to something important. Now, 10 facts inside a paragraph need not be so important. 1 or 2 will be important. Okay, so remember that. You should be sure about what you write. Sometimes students talk about, they quote authors, they quote workers in the area, and they write with great confidence that so-and-so said this or so-and-so said that. Nobody has asked you to quote in the examination, in the theory paper. If you are quoting, you should better be sure that what you're quoting is fact and not fiction. For example, Spitzer and co-workers gave the concept of first rank symptoms. Any first year student who's listening to this talk there will know that this is utter rubbish. Okay? Or Ishwar Chandra Vidyasagar was responsible for starting psychosurgery in India. Rubbish. So don't quote names unless you're very sure that you can really attribute it to those authors, because you get caught out, and it puts a seed of doubt in your examiner's head that why is this guy doing this? Okay. Again, avoid obfuscating, avoid beating around the bush. Okay. For example, Koro is very common in China, as noted by a famous psychiatrist. Which famous psychiatrist? Everyone knows that women are more depressed than men. Who is everyone? Okay, a series of important researches published by WHO have shown that lifetime risk of suicide is basically the candidate wants to impress, doesn't know what knowledge to put and whom to quote, and he's basically beating around the bush. This sort of answers don't fetch you any marks. Okay. Now be as clear and precise as possible. As clear and precise. Use flow diagrams to aid understandability. That's easy. You can write a whole short answer in just flow diagram. There's no problem at all. Answer only what is asked. Please don't answer stuff that has not been asked because you're wasting time. The question is on FRS, I think, and the answer is schizophrenia occurs in 1% of the population, causes devastation, etc., etc., etc. You're at the end of the paragraph, you're still not reached the original question. This is a waste of time. You will not get any marks for what you have written. So do not include irrelevant and tiring details into your answers. Stick to usually accepted classifications like ICD or DSM. And importantly, at the end of the paper, please keep 5 to 10 minutes to review your paper and to go over and see if you have missed out anything, if you have missed a question, if you suddenly remembered certain things that you add on into the margin. So keep that. Okay, keep a 5 to 10 minute buffer for yourself. Remember that each paper matters. It's about 100 marks for each paper. Now, next is after the paper what? Use your ability to introspect, to realize the deficiencies in your answer script. You will know, if you think, where you have fallen short and where you have done well. And then go and read up on it. Because sometimes in the Viva, you may be asked the same areas. And if you then show up as not having read up, that's not going to be a very nice impression to create for the examiners. Coming to the case presentations. Now, this is important. Do your case presentations in content and style and answer the Viva the way you have been taught in your department in the past 3 years. Don't try doing anything special. Don't try to be different. Okay, you just do what you have been doing and taught every day for the last 36 months, and you will be fine, and your faculty who are the internals will be there to look after you. If the externals feel that you are going off the track, they can say, okay, this is how we teach them in our department. So please don't try anything different on the D-Day. Coming to the long case, usually you'll get an R. It's given for a full evaluation, including a physical examination. Do write notes. Don't say I will remember everything. Do write notes in whatever shorthand you want to use and read off them in the presentation. Okay, don't try to do extempore, because if you're anxious at that time, you may not be able to. So have some notes in your hand. Finish presentation within 15 or max 20 minutes, leaving 30 to 40 minutes for discussion, because that's where you will be given a chance to show your knowledge. Avoid trivial details if they take up too much time. Use discretion to save time. If there's a particular area which you feel there's not enough time and it's not important for this case, don't ask that area. But you must tell that you have not asked it because of lack of time. Don't say I asked it and fabricate some answer. Say that this part I could not ask because there was not enough time. Any examiner will accept that. Again, avoid a litany of complaints about the patient or the informant. Don't say patient was uncooperative, he did not talk to me, he ran away, informant ran away. All that information is already there with your examiner, because your expert would have given that information to you. But when you start your presentation in this negative way, it creates a very poor impression. Verbatim, chief complaints should be in verbatim in the language that they have been spoken. History
I think sir has some problem. Let me check.
I spoke with him, Chindan. He will log in again. He will log in again. I spoke with him.
Fine. Thank you. Wait for 2 minutes. Sir is joining again.
Hello, am I audible?
Yes, sir. You can share now.
Yeah.
I make you go.
I will have to share again, I think.
Yes, sir.
Okay, I'm sorry that something happened, but I'm back here. Am I audible now?
Yes, sir. Yes, sir.
Yeah. So your history for the long case should be detailed, including levels of dysfunction. Remember that the course of the illness, treatment response, apart from phenomenological details and evolution or subsidence of symptoms and behavior. Try to incorporate or embed in the history relevant diagnostic criteria of ICD. That means bring out the diagnostic criteria in your history. Okay. And there should be a reasonable additional history that you should do whenever you're taking a particular patient. For example, if you have a patient with depression, a reasonable additional history you should do is whether there's a history of anxiety, panic, phobia, obsession, depersonalization, derealization, dissociation, somatoform, ISH, endocrinopathy, substance use and substance withdrawal, any CNS disorders and psychotic symptoms. That will be reasonable because that sort of rules out an organic etiology. So remember always to have a reasonable additional history. Talk about stressors, a description in reasonable details of the contextual factors, if any, and you have to make a judgment whether it was a precipitating factor or it was only a stressor. And also understand the psychological context and impact of the stress on the patient. Okay, that's important. And that will come with time for you. Family history, interpret the available data cautiously. Don't say just because somebody had 2 episodes of mental illness in an uncle, don't say it is bipolar disorder. Your patient with whom you're talking itself, you have so much difficulty in making a diagnosis. How can you make a diagnosis of somebody who is a second degree relative where the information you know is 2 episodes of illness? So be cautious when you make those assumptions. There should be a genogram, and what are the supports that the patient has, and what about the environmental supports he has. Personal history, of course, the relevant details, but linkages with known theory should be there. And then educational, sexual and occupational, you may not have time sometimes. Own up if you haven't got the information, doesn't matter. The examiner will understand. Menstrual histories, comment about PMS, PMDD. Follow the format that is taught to you in your, about premorbid personality. Don't ad lib. Do the way you have been taught to do in your last 3 years. Physical examination is a must, okay, including the optic fundus. And as I said earlier, when you start presenting, don't start with patient not cooperative, not enough time, patient won't talk, etc. Present what you have in the order practiced in your department. Don't contradict yourself in your observation. Once you say patient is not attentive, then say patient is very cooperative. You know, in that anxiety, we make those sort of mistakes. Elicit and mention the psychopathological phenomena over the last week in your MSc. Remember, the MSc is always over the last week. Elicit and mention thoroughly. Common confusions in the mental status examination: how to test for proverbs, how to test for memory, how to test for judgment, what are the components of intelligence, what is mood, what is affect, what are the descriptors of mood and affect, what is the difference between form and content, what are the descriptors of delusions, then what are the what is systematization, what are the vectors, what is the pseudo community, what is congruence and incongruence of the mood, how should you elicit and interpret formal thought disorder, what is the difference between depersonalization and derealization, what is subjective space and objective space, where do first rank symptoms figure in your mental status examination, how do you grade insight. So all these are common problems of which you will be asked about, and you can tell them whatever you have learned and you've been taught. Remember to differentiate between a summary and a formulation. They are very different. Okay, the formulation is your understanding and your theoretical creative interpretation of how the patient reached this stage. The summary is just a summary of the information you have. So decide which one you are presenting, or the teacher or the examiner will ask you, okay, present the formulation, present the summary. You should be ready with either of them. Okay, so you should be able to switch over from summary to formulation or vice versa. As I said earlier, embed the ICD-10 or in future ICD-11 criteria in the formulation. When necessary, give differential diagnosis with points for and against in the order of likelihood. But don't be extravagant in your differential diagnosis. For example, patient has a 6-month history of suspiciousness, acting out behavior, talking, smiling to self, being aloof, sometimes weeping, refusing food, threatening ISH, decline in all areas of functioning is known, and there's no substance use. And the differential diagnosis: organic mental disorder, schizophrenia, depression, delusional disorder, ATPD, and so on. So that's an unreasonable differential diagnosis. Nobody is going to be happy with that. Discussion of your findings and diagnosis, don't be suggestible. Sometimes the examiner will try to pull your leg. He'll say, okay, you said this, but you also said this. Don't you think this other diagnosis is possible? Think about it logically and tell what you think. You don't have to follow whatever trap that is laid. You can stick to your findings and then say that, look, I think this is it. If you want, I can further clarify. Okay, make it nice. Don't get into a controversial or confrontational situation. At the same time, when you're really muffed up, don't be mulish. When there is data that the diagnosis probably is something else, then be flexible. Okay, sir, if that finding is also there, then I will entertain this diagnosis also. So basically be flexible in your thinking. Now, the diagnosis also, remember, is made along the course of the illness, not only on the cross section that you are seeing. So factor this in when you think of your patient that you're seeing. You know, take this for example. This is a 30-year-old who presented with a history of disturbed talking to self, wandering, gesticulating, decline in functioning 2 years ago, which lasted for 2 weeks. He was given something and for a month, and then he's okay. By 2 weeks of treatment, disturbed treatment was better. Treatment was stopped after 2 months. He remained somewhat withdrawn, not spontaneous, not working as well as before, asocial, till he was brought with a suicidal attempt. When you formulate this, don't forget that you need to take the whole course into consideration, not just the suicidal attempt, not just the probable psychosis 2 years ago. So you need to think along those lines when you propose your diagnosis. Management, what are the components of management, especially if there is a differential diagnosis? Remember, this is a very cardinal mistake. If you say, I have a differential between depression with psychotic symptoms and schizophrenia, what is the first thing that you will tell in the management? You will say, I will inquire further to clarify whether it is depression or whether it is schizophrenia. Just don't say, I will start treatment with antidepressant, ECT, etc. Then there's no point in calling it a differential diagnosis. This point is that when you had a doubt and you had two diagnoses, you first make further inquiry, you do clarification, you can do tests on them, psychological tests, whatever, and then clarify and reach a conclusion. You can do psychometric assessments and then arrive at a working diagnosis, and then you can make your pharmacological or psychosocial management plans. Be prepared also with prognostic factors, likely course and outcome of that illness, associated legal and other forensic issues, theory linked to the case at hand. Remember that the long case again is usually 100 marks. It's quite a lot of marks. What are the abnormal behaviors seen during case presentation by the students? Frequent shuffling of papers. Please number your papers and staple them so that you don't come to the examination hall. In your anxiety, you mix up the papers and you keep turning them this side and that side. Write numbers and pin them. Hyper anxious, restless, jumpy students, hyperactive students, not maintaining eye contact, low volume speech, sometimes unfortunately swooning with anxiety, extensive pauses and silences, and please avoid tears in the examination hall. Okay, you should, by 3 years, you know, you have been a postgraduate, you're going to be a consultant, you don't need those tears. Regarding the neurology case, what are the expectations? A detailed history is expected, an adequate general physical and systemic examination, a detailed neurological examination, an ability to reach a broad diagnosis of the type of neurological lesion, localization and etiopathology. If it is possible for you, fine. If it is not, even that is okay, that can come up in the discussion. And the basics of treatment, but invariably psychiatric aspects will also be asked. So you should be prepared with these. When you are examining the patient, whether the examiner is there or not there, please seek permission to examine explicitly, expose the part to be examined adequately, examine from the right side of the patient. Correct elicitation of signs is important. That's what the examiner is looking for, not your diagnosis making, but whether you have followed the correct method. So read from Bickerstaff or De Jong or whatever, learn from your neurology teachers, but do the correct elicitation. Follow textbook descriptions for elicitation, as I said. Examine each sign, normal side first, then the abnormal side. Always remember carotid and peripheral pulses, thyroid, skull, spine, gait. These are often missed. A systematic and thorough examination is needed. When you cannot do a particular assessment, better inform the examiner. Patient is lying down, he's got hemiparesis, you cannot do confrontation. You tell the examiner, I could not do confrontation. It is understood. Don't say I did confrontation. Then the examiner will ask the patient, did he do confrontation? Done, you're done for. Okay, so examiners have a nasty habit of asking the patient or the informant if a particular test was done or not. So why risk it? Okay, remember neurology cases usually about 50 marks, so it's quite a lot of marks, so you should be pretty well prepared. Short cases, the patterns differ across centers. Usually they ask for a brief history and an examination. That's a common method. Spotters are given in some places. Strictly comply with the instructions given to you. If the instruction that the examiner told you is do a brief history of present illness and MSc, do only that. Don't start doing family history, personal history, etc. You're wasting time. You will not get any marks for that. Okay. Now, discussion usually is about eliciting phenomenology, interview technique, differential diagnosis, management, and so on. Remember, short cases, maybe 30 or 25 marks, depending on OSCEs. If you have OSCEs, if you don't have OSCEs, short cases is more. If you have OSCEs, short case has less marks. Remember, in your clinics, please do not ask for the diagnosis of your patient from anyone. Your juniors, your seniors, the ward staff, the nurse, please don't ask it. It can cause you more harm than good. Remember, in your training itself, you have seen that the patient, when you take the history and interview the previous evening after admission, he or she tells you some phenomenology. Next day morning, when the faculty comes for rounds, the phenomenology changes and you look sheepish. Now, remember, this can happen here also. What the examiner wants is what you have observed, okay, not what somebody else has told you. And it can be very risky for you if you ask for the diagnosis and try to fit the findings to a diagnosis which may be dubious in nature. So please remember this always. If you have OSCEs, it's great because you will have lots of marks, usually 4 or 5 OSCEs for 20 to 25 marks. This is where you can score very well. No questions will be asked by the examiner usually, and your skill in performing the task at hand will be what is assessed in OSCEs. Viva. There can be many patterns. It can be table-wise. For example, psychology here, psychiatry there, specialty is there, neurology there, and so on. Or it can be haphazard also. The examiner time may be limited per candidate, or it may be unlimited. It depends. Starting of the Viva, the examiner may start randomly. He may start with your thesis, with your theory paper, lacunae, favorite area. Questioning may be facts, concepts, or a mixture of both. When you don't know the answer, please say it upfront. Sir, I don't know the answer. Okay. You save time. You can go on to another question which you may be able to answer. Be modestly confident about your ability. You can showcase your special areas of expertise if you have the opportunity, but don't try to hijack the Viva. Don't drag the examiner in the Viva. You won't be able to. It won't work. And don't get flustered if you do not answer a few questions. Out of 10 questions, if you don't answer 2 or 3, it's all right. It's par for the course. Don't worry about it. And if you're asked area of interest, please be sure that you mention your strong suit, things you know well. Otherwise, say, sir, I'm okay with anything. Okay, because if you commit that this is your area of interest, they may take you very deep into that area. So be sure about what is your area of interest and then only commit to that. Speak clearly, maintain eye contact with the examiner. Beware of the sleeping examiner. You think he's sleeping after lunch. Suddenly he'll pounce at you with some question. So be careful. Nobody is sleeping there. Importance of the Viva cannot be overemphasized. It can mean passing or not in some cases. And Viva VOC will be maybe 100 marks in most centers with one large station or 4 stations of 25 marks each. So in conclusion, I want to say that if you have been doing your work in the department as per protocol and to the satisfaction of your faculty, you will definitely pass. If you have been systematic and keen throughout your course, you will pass. And if you have shown interest to learn consistently without bias against any subject, you will definitely pass. Best wishes to all the students and greetings to all their teachers. Thank you very much.
Thank you, sir, for your lucrative lecture. It is going to really help the PG students from first to even just now who are going to attend the exam. So now session is open for question answer. So PGs are requested to send the question in the chat box.
Somebody has raised the hand rather than use the chat box. I think there is some two people have raised some comment or question.
That is just thank you, sir. Thank you for something.
Oh, okay, fine.
Yes. Now questions are coming. Question from Dr. Versa, SRC Bangalore, that I find very difficult, or maybe just I don't like to in remembering the evolution of psychiatry, the names, years, etc. Is frequent studying the only way out, or is there any mnemonics, videos, compilation, etc. that can help on us?
Okay. The whole idea of understanding the concept is to know how today, where you stand today, has evolved over time. Remembering something by mnemonics is fine. You can make mnemonics, you can find books with mnemonics also. But the problem is that they don't convey that inner meaning of how a concept has evolved, how things have evolved. Even take, for example, even schizophrenia. How have the current description of schizophrenia evolved over the past 150 or so years? It tells you also the direction in which research has happened, and also will tell you in direction in which the research is going to happen in future. As a future faculty member, that's important for you when you go and start talking to your students about it. Only mnemonics may just help you in remembering certain names, but what the thought which went behind it is probably very important. Okay, so yeah, there are small books which talk about mnemonics in psychiatry or in medical science also, but I personally would not recommend that way of doing things.
Fine. So another question by Abhishek Gupta, that as time is limited for neurological case and we are unable to do full examination, so shall that to be told to the examiner that we could not do?
See, Dr. Gupta, it depends on your exam pattern and how much time is given for neurology case also. Some places they give 1 hour, some places they give 45 minutes. Okay, now you in your posting of 2 months or 3 months in neurology, you are expected to learn how to do a quick neurological examination. Okay, it's a procedure. And it also depends upon the sort of patient that you've got. If you have got a patient who unfortunately has a stroke, there are certain things that you cannot do. Automatically, time is saved for you there. Okay. But if you've got a patient with movement disorder, there are certain things which are glaring and the other stuff will happen very quickly. So it's only thing is where you can save in that sense of the term is that supposing you have had a difficult patient, and let us say it is a patient with dementia, and you've had difficulty in getting the cooperation to do a detailed cognitive function testing and history taking, and you are not able to do the lobe functions, you can always tell your examiner that, look, I have not had time enough for doing the lobe functions. And if I have more time, I can do them. And then the examiner will say, okay, what are the lobe functions you will do? And then you tell them what you will do, and that will close the chapter. Okay, so one, you have to repeatedly practice doing a proper neurological examination, even on every psychiatry patient that you are examining in your OPD or ward. That will give you the skill to do things fast. And two, you have to use your judgment at the time when time is limited. And your examiners will understand. Don't worry about that. Your expert examiner will tell the examiners what is possible and what is not possible with that index patient. So don't be scared about that.
Thank you, sir. Sir, you can stop your slide sharing so you can be visible to all.
Okay.
Next question from Dr. Rahul Amrita Kochi, that if in a long case, the patient tells us the drug he has been on, and then we are asked about how we would manage the patient, how do we go about it?
You mean to say that the patient has told you that he has taken so and so medication? That's fine. You include it in the history. There's nothing wrong with that. It's part of the history. And then if you want to improve on it, you can improve on it. Supposing he was taking only 400 mg of lithium and he is in mania, so you will tell the teachers that, look, examiner, that look, this probably is a subtherapeutic dose. I will increase the dose and do serum lithium. It's perfectly fine. The information that is given to you, that is with them, is your information. It is understood. Okay. If they don't want to give you that information, they will hide that. For example, in many places, they hide the case file about 5-6 days before the examination, the ward patient's case file, which means they don't want you to see that information. But if the patient tells you, I was on olanzapine or whatever it is, you tell them what he was on, and you say that if this is the reliable thing, I will do this. I will increase olanzapine, or I will stop it because there was no response. I will try something else. Perfectly fine.
Thank you, sir. Next question is from Surbhi Surendran. There are difference of opinion regarding diagnostic formulation even in our college. So what is the best way to do it?
Look, this is something which needs to be practiced. It will take a lot of time, but what I'll tell you is this much. The summary is just the facts that you have gathered from the history and mental status examination and physical examination. The formulation is how you understand or conceptualize the patient's problem, which means what are the etiological factors that were playing on him, either stressors or genetic or whatever, how he responded, how his psychological response was to those stressors, how he or she broke down, what are the support systems that he has, what are the likely problems that in that sense that he has now, and hence you can arrive with a formulation. You can arrive also at the management plan very easily, a logical management plan. With a summary, it's just ABCD, again, the history in a small capsule form. So it does not logically lead to a formulation, whereas a management plan, whereas a formulation does. So the formulation draws on your own theoretical knowledge also. Okay, if you have found that there has been childhood abuse and you are linking it up to current depression, that is because of your theoretical knowledge. That will come into your formulation. Understand? So this is something that is complicated, but actually it reflects the way we think about a patient. So that is what is being assessed in the exam.
Fine, sir. So next question is somewhat, if you can, how does one overcome one's own reservation and less than expected people skills? Dr. Sheena Shah from Imans, Kashmir.
I can only tell you that you should relax and keep talking to your patients, and they will teach you how to talk to them. Okay, and they will show you. When you talk in a particular way, they will open up, and when you talk in another way, they do not open up. Spend time with your patients. If you have 4 patients in the ward, spend at least 45 minutes with each of them every day, and you will learn. The only way to really learn clinical skills is with your patients. Whatever we teach you is just guidelines. Okay, and the same holds true for therapy also. So just spend time. Don't be inhibited about spending time. You don't have to keep asking them, what are your hallucinations? What are your delusions? You can ask them, what is your home circumstances? Or you can ask them, what are the things that worry you? What worries you about your son or your daughter? Or what are the problems that you have faced in your life? You know, talk about those things which they are comfortable with. And then you'll notice that you start vibing with them, just like you talk to your friends. And that's what you should learn. So spend time with your patients.
Thank you, sir. That's great thing. So Dr. Samrat, PG final year, St. John, Karnataka. What is the appropriate way to describe the quality of, in inverted comma, normal affect on MSc? Is euthymic a term accepted in general?
See, there are different points of view about this. Let me make it very clear. The term euthymic is generally understood as something to do with mood disorder, especially bipolar disorder. And it's a historical term that over a period of time, this person's mood has not varied very grossly. Okay, the word you, like, is nice or okay, thymia. right? So you do it for a period of time. Affect is something that you're talking about now, what you're seeing on the patient's face and his non-verbal communication during the course of your interview with him. So you don't use euthymia there. You can just describe what are the affects that you have seen on him in the last 30 minutes that you're talking to him. You will find that there were times when he was anxious, there were times when he was happy, there were times when he was sad, or times when he was angry. You can describe those. So quality of affect is the real name that you give to that affective response that you see on the patient. Obviously, for 30 minutes, he will not show the same affect state. Okay, unless he's, of course, a euphoric, manic, or something like that. So you can just describe that and say that the affect is a mixture of this over the period of the interview. But it has to be something to do with your period of interviewing him. It is not a historical.
Fine. So Dr. Hasini Thakkar Vimans Vijayawada wants to say that, good evening, sir. You mentioned that we need to read multiple textbooks, but how do we compile them into one place for reading at the last phase before our exam? Or we have two phases of reading, means exam oriented and knowledge oriented.
See, what I was trying to tell you was the last 6 months, 30 months to 36 months, is when you will be reading the notes and other things that you have accumulated over the first 30 months. Remember that you started in the first 6 months with a very basic textbook of psychiatry, very simple basic textbook. By the next 6 months, you have started looking at a textbook which is with multi-author or single author or a mixture of multi and single author. Remember, I also told you that you need to make notes. Okay, you need to write somewhere what you have read up. Okay, by the time you have crossed 2 years, you've already reached the stage where you're reading review articles and guidelines and things like that. A body of knowledge has built up in your mind, which is again reinforced by the notes that you have written. So in the last 6 months, this is what you will be reading. It is a distillate of all that you have read, probably a few new things, and that you should have at least, what I said is 3 readings. In the 6 months, you should, first 3 months, you should do 1 reading, and then the next 2 months, another reading, and the last month, one final quick reading. Basically to reinforce that knowledge. And remember, that knowledge which gets reinforced now before the examination is not just for the examination. It is going to be a building block for you for the rest of your life as a mental health professional. So it has to have a very long impact. So you're right, you should read in stages.
Yes, sir. Next question is, how should we take pre-morbid history in short term during exam? Question from Sen A.
See, there are different formats that are used. Some places use the old Mayer-Gross's format of taking pre-morbid personality. Some places have a very structured pre-morbid personality. I would suggest that you follow what is being done in your department. Okay, I don't want to impose on it because in 2 minutes I can't tell you how to do a pre-morbid personality thing. But it is necessary. The reason being that you want to know what his level was before he decompensated and what you expect him to go back to, and how that pre-morbid personality has had a pathoplastic effect on his current illness. So you can't go away from it. Of course, I agree with you that if your patient is being a little difficult or the time is less, or you've not had the time for eliciting a proper pre-morbid personality, that is fine. You can tell the examiner that. No examiner will be unkind enough to tell you that this is bad and you should fail and things like that. Nobody in these days does that. Okay, so but a pre-morbid personality, do it the way you've been doing it for the last 3 years, because your teachers have been correcting you if you have been making mistakes. Follow that format, or follow the Mayer-Gross format, or follow any other textbook format that is used in your department.
Thank you, sir. Next question from Dr. Gulesh Kumar, CIP Ranchi. That, sir, we already lost 1 year to prevailing COVID situation. So how we go from here to timeline you suggested?
I know my talk is probably better aimed at the people who are going to join or who are joining now. Okay, in the sense that it starts from the entry point. I know that the last 2 years have been terrible. and I understand that your training, especially the current second years and third years training, has been badly compromised, and there's very little that can be done about it, except my only suggestion is that if you have the time and if you have the ability to, I would suggest that you continue to work in your department for at least 6 months more after your MD exam. So and try to patch up that. Theory you can learn, you can read, even now you can make up, but the problem will really be the practice part of it. That has been compromised, and that is something that you may have to fill up with some extra time. It's unfortunate, I agree with you. We've had residents who've been sitting in COVID wards also and not be able to do anything in psychiatry for weeks on end, but it's all over the country and probably all over the world. So the theory you can read, the practice I suggest, if it is possible, try to do some sort of observership or interning or something for a few months after your MD also, before you start practicing or joining a college or something.
Fine, sir. Next question from Dr. Papaya, MG NCRI, Pondicherry. Sir, if uncooperative patient, no psychopathy established, what to do for MSc, sir? Can I present Kirby's method in that case?
Yeah. Good old Kirby in 1936 or 1934 is still accepted. Not a problem. If there is catatonic signs, you can use any of the catatonia scales. Otherwise, you use Kirby. Give a proper, good description of physical appearance and behavior.
Fine. Next question from Rananjay Bhaumik, which may be common to all, like different examiners are from different schools of thought. Based on their seniority, some are more psychodynamic oriented, some are organic based. The poor students is caught because psychiatry hasn't found out the specific etiology and can be led anywhere depending on their Viva examiner. So what do you prepare for the last day before the exam?
Last day before the exam, I ask you to have a nice meal and sleep early. Okay, because you're not going to be able to fill any voids on the last day. You'll just be more anxious if you stay awake in the night and try to read. But I understand your point, but if you look at your textbooks, for example, any of the modern textbooks that you read, they do give a representation for what you call psychodynamics or biological psychiatry or cognitive psychology or whatever it is. They all give all representation to all of them, which means that we should be aware of all of them. It's not that it's the pet fancy of the examiner. And believe me, the examiner is not going to ask you what he knows or all the lot that he may be knowing. He's just asking you what he thinks is a benchmark. That's all. Okay. So don't be scared about it. Read the basics in all the areas that your teachers have taught you. That's all you need to know. And nobody is going to, if the examiner is going that extra length, then you can celebrate, because that means you're going to pass very well in the exam. Okay. But otherwise, these are things which are there in your books. You can read about them. You will be able to answer the basics of all these things. That's all that is required. And I tell you one thing, over the years, I mean, I'm not boasting or anything, but I've been an examiner from 1993. I'm quite ancient in that way. And there has been a change in the way examiners look at exams in all specialties, not only psychiatry. People look at not esoteric stuff, not vague, crazy things which are printed in one journal once in a year. They ask for common things that you do every day, you know. And so the examiners are very reasonable. Don't bother about them. Even if somebody asks you to pull your leg something odd, it is just for a laugh, that's all. But you need to cover all bases. You need to know your biological psychiatry, you need to know your dynamics, your social psychiatry, everything, some amount, which is what your department will give you.
Thank you, sir. So next question, Dr. Kudrat Jain. In how much depth should we know the psychological test for Viva purpose?
See, again, it differs. At the places I have been, I can tell you that they usually have the common IQ tests, the common projective tests, some of the neuropsychological tests, and a few personality tests. These are the things that are commonly said. For example, the Tower of London and Wisconsin-Carteret and Stroop and trail making will be there. There will be Binet Kamat. There will be Weiss. There'll be MMPI, there'll be Rorschach TAT or CAT. These are the sort of thing that will be usually asked.
That is question from Likhin SP regarding DNB. The DNB exams usually we have centers in some other states. Usually sample of speech has been to be in patient in own words. So translator will be helping the same. There are higher chances students may in wrong interpretation of the same MSc. How to overcome the same?
Your examiner will also realize that you have that problem. Don't worry. Okay. We know that there is a problem, and a certain margin will be left for that.
Fine. Dr. Divya IMH Chennai. Sir, is it appropriate to document the presence of formal thought disorder in the caretakers while they elaborate the history as a marker of schizophrenia or justification of the longer time needed for a good history?
No. See, listen, when you are talking about formal thought disorder, it is not just any sample of speech. Okay. I'll tell you a funny thing. A long time ago, there was a president called President Nixon in the USA. Somebody took a transcript of his speech and gave it to a bunch of psychiatrists and psychologists without telling them who the person was who spoke those words. 75% of them rated him positive for formal thought disorder. And that applies to us also. So it's not that you can just pick up whatever that relative is saying and then call it formal thought disorder and then say, so this person is having schizophrenia. Firstly, that is not the index patient. Secondly, the link between parental or family members thought disorder and the patient's thought disorder is not just based on clinical formal thought disorder, but there are other tests involved. Okay, so don't make that mistake. You get a sample by giving a topic which is not emotionally charged and which is neutral, which is open-ended, and then record the sample of the patient in the language that he or she is speaking, and then analyze it and give your comments. Don't go into all this other stuff because the clinical bedside is not a theory lab.
Fine. One clear question from the Ajitra JK. Sir, is there any specific book or articles to understand on phenomenology of Indian patients?
There are many books written by Indian psychiatrists regarding phenomenology and descriptive psychopathology with some hints regarding cultural variations and so on, if that is what you're referring to. There are many. All of them are available freely. There's one from CIP, there was one from Haryana, a couple of others also at postgraduate level. I'm not talking about undergraduate level. The rest you will have to probably focus more on your seminars to understand that.
Fine. There are two questions which is likely somewhat different. Sir, could you explain communicability part of mood? That is a kind of theoretical question.
I don't know whether this is supposed to be the venue for that, but I'll try.
You can just brief.
Yeah. So, for example, when you are talking to a person who has, let us say, is a euphoric or an elated mania, and he's talking to you, and do you feel that your mood also is sort of lifting up a little? You also start feeling a little cheerful. If you do, that is communicability. Similarly, if you're talking to your friend, he's very sad. Let us say something bad has happened in his life, and he's very low, and you're trying to console him. And then you also find that your own effect has gone down a notch or two. That is communicability. And the whole idea of this communicability is because very ancient, because it is that there is, according to some people in the 1920s, said that there is a glass wall sort of a feeling between you and a patient with schizophrenia. Okay. And so you do not have that effective response or communicability with them that you have with other people. And so this entered into your mental status examination to make a distinction that people with, say, schizophrenia, autism, and certain types of disorders, communicability is not there. Okay. Now there are very many exceptions for this. You can debate it, but this is the origins of this communicability thing, and this is what it means. In normal life also, we experience it. When somebody is very happy and cheerful, he got a promotion, he's won a lottery, he's telling you, you also feel nice. That's communicable. Okay.
Thank you, sir. And we are ending towards the last question from Palak Patel. In past psychiatry history, there will be variable details at different institute. How much detail of the past episode should be given? We should include everything or up to which extent?
See, I had referred to this point in terms of family history. The point is that sometimes your past history will be a very strong indicator for you of current diagnosis as well as current response to treatment. So as much detail as possible is necessary. Don't, with a little bit of detail, don't jump to a diagnostic conclusion, because with the current details that you have of your patient, also you have so much difficulty in making a diagnosis. With something very blurred which happened 10 years ago, firstly, the details will not be enough. Secondly, there has been a lot of memory problems involved. So it better take as much detail as possible and then be cautious in how you interpret it in connection with the present history. Okay, but details are necessary, especially when you have a good informant. You're very lucky.
Thank you, sir, for there are some comments. They are thanking you. And somebody has mentioned that even after hearing your lecture, they feel confident to go ahead with the examination.
Okay.
Chintan and sir, there is one question raised in YouTube. Please let me read that out. From Dr. Vaishali Reddy. She is asking, I wanted to know if other than case vignettes, do you recommend any other strategies to help critically analyze or come up with a management plan for the cases I might not see in my residency? She is from Father Muller's Mangalore.
Yeah, see, what you need to focus on in your residency, you will yourself see many patients. You will probably, in an average sort of a setting, you will probably do at least 100 detailed evaluations in your three years of training in psychiatry, which is a lot. Okay, you'll probably see 200 to 300 new patients briefly. That's a lot also. All that material is sufficient for you to start planning on, practicing on management plans. Case vignettes are not to make management plans which are pakka. Case vignettes are to understand what could be the possible diagnosis and what further clarifications you need to narrow down on your diagnosis. Okay, so I gave case vignettes as a way to understand the presentations of psychiatric disorders, not necessarily for making pakka management plan. Yes, you can make a very loose sort of a management plan on the basis